I'm very excited to introduce to you Amalie Kass, who is lecturer in the Department of Social Medicine at Harvard Medical School. And she's going to be talking to us today about Dr. Walter Channing. And the title of her lecture today and book is called Midwifery and Medicine in Boston. One final announcement I forgot to mention. Our lecture today is being filmed by WGBH, and if you want to watch the lecture later or know anyone who couldn't make it, you can go to wgbh.org/forum, F-O-R-U-M, and watch it all over again or refer it to a friend. Please help me in welcoming Amalie Kass. Thank you.
Well, thank you very much. I don't think I've ever had the fun of speaking in such a venerable and tradition-bound venue as this, so it's really a great pleasure and a great honor for me. I am especially honored to lead off in this series of lunch talks dedicated to medicine in Boston. It's a subject that is near and dear to my heart, and I hope that at the conclusion of the series, some weeks hence, it will have captured your interest and your enthusiasm. Boston has a remarkable history of physicians and medical scientists who have made significant contributions to the growth of medical knowledge and improved care of the sick. My talk today on midwifery and medicine in Boston focuses on Walter Channing, who is the subject of a biography that I wrote about him that was published just a few years ago. And as Michelle just mentioned, there are copies of the book for sale, and I would be honored to inscribe anyone who purchases one. Channing is appropriate to this series for several reasons. First, his career reveals many aspects of medicine in the 18th and 19th century that are very different from medicine as practiced today. They probably will seem pretty crude to you, yet for their time, they were solidly grounded in the then best available medical knowledge. Second, this is very much a Boston story. Walter Channing was born in Newport, Rhode Island, where several generations of his family had been prominent merchants and lawyers. His maternal grandfather, William Ellery, had actually signed the Declaration of Independence on behalf of Rhode Island. But Walter's generation migrated to Boston in the early years of the 19th century, following their older brother, William Ellery Channing, who was appointed minister at the Federal Street Church in 1803 and is still remembered and honored as a prominent Unitarian minister, a brilliant lecturer, and an important social reformer. So all the scenes from Walter Channing's adult life are Boston scenes. For many years, he and his own family lived just up the street at the corner of Tremont and School Streets, where the Omni Parker Hotel is today. They worshiped at the Federal Street Church. Naturally, his brother was the minister, and the Federal Street Church was then on Federal Street Church, although it subsequently moved up to Arlington Street. Harvard Medical School was on Mason Street, just a couple blocks up from here, one block in from Tremont. The Mass General Hospital was a single building. Today's Bullfinch building is the original building of the Mass General Hospital, and it was then right next to the Charles River. The topography of that part of Boston has been greatly altered, considerably altered, by the construction of dams and creation of additional land with fill. But in the early days, many patients came to the Mass General by boat, and there was a pier where the boats landed and they were carried on up to the hospital. And there are wonderful photographs of that if you ever get to see them. Now, Walter Channing practiced medicine in Boston from 1811 until after the Civil War. He lived a long life. He was 90 years old when he died. And if you ever write a biography, choose somebody who dies young. Channing had an extensive general medical practice. Indeed, he could not have made a living unless he also took care of patients with pneumonias, dyspepsia, fever and inflamed throats, cancers, tuberculosis, rheumatism, and every other complaint and disease that were part of general medicine. He took care of sick children, too. Doctors did not specialize in pediatrics or geriatrics or obstetrics in the 19th century, and a physician had to be able to respond to every kind of medical problem. But he made his reputation, and it's for this that I was interested in him, as 19th century Boston's best-known obstetrician. Not only was his own patient list extensive, but many other physicians turned to him for consultations when they ran into difficulties. He was the first professor of midwifery, as obstetrics was then called in academic circles, at Harvard Medical School, and he filled that post nearly 40 years, instructing generations of medical students in what he called the art of midwifery. He was the first dean of the faculty at Harvard Medical School. There were only 5 professors when Channing became the dean in 1819, and only 7 when he gave up the deanship nearly 30 years later. Being dean was not a very onerous task. He kept the minutes and he did a bit of correspondence with the president of the university, but there was no fundraising, there were no government contracts to worry about, none of the kinds of things that preoccupy deans today. Channing was one of the founders of the New England Journal of Medicine and Surgery and a founding editor of the Boston Medical Journal. He was instrumental in the foundation of the Boston Lying-In Hospital. That was the precursor, if you will, to Brigham and Women's. Some of you, I'm sure, remember the Boston Lying-In Hospital. That's where I had my first child. He was only one of 2 physicians on the medical staff of the Massachusetts General Hospital when it opened its doors to patients in 1821. And he held many other important firsts at a time when the medical profession was pretty much in its infancy. Now, one thing I want to make clear, because I suspect that already you say, I've trapped her, what's she talking about here? The terms obstetrics and midwifery were used interchangeably for many years. In Britain, when men first began to deliver babies, they were called man midwives. That term never caught on in this country, but their field of medical endeavor was called midwifery well into the 19th century. As I mentioned before, Channing was professor of midwifery, and that title prevailed at Harvard Medical School long after he retired. In our country, male practitioners of midwifery were called obstetricians, and the women whom some expectant mothers continued to prefer to have attend them in childbirth were called the midwives. However, as I indicated before, Channing was not an obstetrician in today's sense of the term. All physicians delivered babies or had to be prepared to deliver babies, and much of Channing's day-to-day practice was general medicine. Now, a bit about Channing's preparation for medical practice. He attended Harvard College for a couple of years before being kicked out for participating in what was called the Rotten Cabbage Rebellion, when the students refused to eat the absolutely horrible food that was served in Commons, and they precipitated a revolt against the administration. And the Harvard administration did not take kindly to that kind of criticism, as it never has. Nonetheless, Channing, once evicted from Harvard, having already decided on a career in medicine, and although there was no licensing system at that time, and it was possible to practice medicine without a medical degree, ambitious men like Channing, especially men who expected to practice medicine in urban settings, wanted the MD degree that indicated formal academic medical study. He never did complete his undergraduate education, but he did go ahead and spend 2 years studying medicine at the University of Pennsylvania and received his MD degree in 1809. The medical school in Philadelphia, University of Pennsylvania, was the oldest in the nation and was considered vastly superior to Harvard or New York, and those were the only other 2 medical schools in the country at that time. During his years in Philadelphia, Channing recognized that he seemed to have a special affinity for obstetrics, midwifery, interchangeable. And so he next spent a year in London and Edinburgh, where obstetrics was better taught than anywhere in our country. Unlike medical schools here, the British medical schools were affiliated with maternity hospitals, where Channing could observe and participate in large numbers of cases, and where he gained great facility with obstetrical instruments. When he returned to Boston in 1811, his ability was quickly recognized by local physicians who had not had his training in obstetrics. And as I said before, much of his practice was consultation with colleagues who needed his expertise and his skill in difficult cases. Obstetrics had only recently become an important branch of medicine. As is obvious, as we all know, from time immemorial, it was women, the midwives, who attended other women in childbirth. And except for unusual cases where a surgeon, going back before even surgery, the butchers, were called in to remove an impacted fetus. But other than that, men were excluded from the birthing room. It was strictly a woman's place. But toward the end of the 18th century, women about to deliver babies wanted the help of physicians, primarily because the physician's education seemed to assure a better outcome. Scientific and medical knowledge by the middle of the 18th, beginning of the 19th century was increasing. And although many things that we recognize today were still unknown, better understanding of anatomy and physiology and the study of obstetrical texts suggested that physicians were better qualified to deal with some of the complications that can happen before, during, or after the birth of a baby. Labor and delivery were considerably more risky then than they are today. There were none of the diagnostic tools that are common now, no X-ray, no fetal monitors to make sure the baby was not failing during a long labor. And in his case books, his case notes, Channing records labors that lasted 60 hours, 72 hours, okay? There were no antibiotics if infection occurred. For the first 35 years of Channing's career, there was no anesthesia to reduce the pain of labor. Lighting in the birthing room was often inadequate. We're talking about candles and eventually gas lamps. Women did not seek prenatal care, and Channing often met his patient for the first time after an anxious husband had arrived breathless on his doorstep, urging him to come quickly. Cesarean section was extremely rare. Channing, in all of his writings, never recorded performing one. And much that is understood about conception and birth now was still a mystery. There were good reasons, then, for women to want as skilled an attendant as was available. Many had a mother, a sister, or a friend who had died in childbirth or suffered debilitating consequences. Many knew of babies or had had babies who died during or shortly after birth. As Channing frequently reminded his students, to whom else in the common walks of life does death come double in a single act but to the practitioners of midwifery? Channing's success can also be attributed to his own personality. Women sought his aid not only because of his education and experience, but also because he was a compassionate, caring physician, providing the very best medicine he could. His patients trusted him. Channing showed great respect for all his patients, regardless of their social class. He even had the habit of addressing non-English speaking women with a few words of their own language, just to gain their respect. His patients had confidence in his ability to make childbirth as safe and easy as possible. He was exquisitely aware of the pain women endured in childbirth and sympathetic to the fear with which they and their families face the uncertainty and risks of labor and delivery, what women often called the ordeal of childbirth. He was keenly aware of what he called the sorrow, the wide, wide misery that he encountered in obstetrical practice. Obstetrics presented difficulties that distinguished it from general medical practice, and I'm talking now about difficulties for the physician. The nature of childbirth meant that a physician could be summoned at any time of the day or night without warning. Channing often slept in the front room of his house so that his family would not be disturbed by nighttime calls. He might have to remain with his patient for many hours, even for several days, without going home. Sometimes, after a hurried walk through the streets of Boston, often at night, the patient was not ready to see him, and he had to wait or return a few hours later. He would be attending the woman at a particularly challenging and intimate time when her fears of pain and death were often stronger than her hopes for a healthy child. Another sharp contrast with today's obstetrical practice, almost all babies were born at home. Channing's attendance in childbirth occurred in the home of the patient, and this was true well into the 20th century. Channing brought his basic equipment with him: a female catheter, sharp scissors and strong thread, lard or oil, drugs such as belladonna, ergot, and laudanum, a lancet, and any other instruments he might need in an emergency. In times, he brought his stethoscope with him, and still later, he often had anesthesia. The largest bedroom in the house was usually set aside for the event. Channing thought the good ventilation was a requisite for health, and he preferred an airy room that was not overheated. A bed would have been prepared, one mattress atop another, covered with a piece of oiled silk, untanned skin, or layers of blankets. If possible, the lower end of the bed was raised so that the woman's pelvis would be higher than the rest of her body. Mattresses were very soft in those days, and Channing wanted to make sure the pelvis was well supported. On 2 occasions, his case notes show that he had a patient who had recently eaten a hearty meal. For one, a breakfast of meat and potatoes while labor was present, and for another, a dinner of baked beans and huckleberry pie. Essentially, therefore, he was a guest in his patient's home, and he had to pay close attention to social mores and decorum. This was a time when female modesty was a highly valued social standard, and any action that seemed to disparage the idea of feminine purity was deemed offensive. When he entered the birthing room, he would exchange pleasantries with his patient, but he relied on the female attendants, her relatives or her friends, to supply information that would be embarrassing for her to discuss. He wore street clothes throughout the entire delivery. The woman would be dressed in a loose-fitting long gown with a cap on her head. He used no rubber gloves at all, and the towel with which he would be expected to wipe his hands was kept hidden from the eyes of the patient so as not to offend her with the sordid details of what was going on. Examination and even delivery were by touch. The patient and the physician's eyes never met, and he was not supposed to be looking at her private parts. That was considered very bad. Unless, of course, Channing or any physician had to turn the baby if it was impacted or it was not facing head down with the back of the head forward, then he would get down to business. He would take off his coat, he would sit down, and he would roll up his shirt sleeves and so on. But otherwise, he stood by the side of the bed, one side to the bed, the patient looking this way, he looking that way, and deliver the baby. This home setting naturally put clear demands on a physician's conduct. If there were complications, severe hemorrhaging, for example, which couldn't be stopped, or an impacted fetus, his personal stress would be augmented by the anxiety of everybody else in the house. If infection occurred, it would be treated at home. In one case, Channing came to the house several times a day for 16 days until the poor woman died of puerperal fever. Puerperal fever, which is virtually unheard of today, was a particularly baffling disease. No one knew what caused it, and no one knew how to stop it or to cure it, but it killed many women and it killed many babies. Channing tried to avoid what was called meddlesome midwifery. That was a term used to caution practitioners against unnecessary interference in childbirth. Yet he could and did employ many interventions when needed. He eased prolonged and difficult labors with opium or by bleeding. When appropriate, he tried to stimulate ineffective contractions with ergot. If the amniotic sac remained intact and seemed to impede the progress of the baby, he punctured it, usually with a sharp fingernail, although on one occasion he wrote about using a large knitting needle. If the baby presented in a difficult position, breech or footling or face forward, he tried to turn the baby in the uterus to a better position. Only in dire circumstances did he take more dramatic steps, using instruments such as forceps to pull the fetus through the birth canal. And the most extreme operation he had to perform was using levers and crotchets to remove an impacted fetus, occasionally compressing the skull if it were a hydrocephalic baby, or the mother's pelvis was too narrow to allow passage of the child. And that wasn't uncommon because so many women had had rickets, so many women were badly nourished, and the pelvic structure was not sufficient to allow passage of the baby without an instrumented birth. The decision to use instruments was always difficult, in part because of the horror of such procedures. Until anesthesia was available, the mother would be conscious, and the rest of the family would be present. Channing always sought the opinion of a colleague before resorting to instruments, and he always informed the mother directly or through the attendants. On a couple of occasions, she or her family refused permission for him to perform to save the woman's life. To quote his case notes, she said she was perfectly easy and would sooner die than submit to any operation. It was already too late, he wrote, and she died a few hours later. No Boston babies were born in a hospital until 1832, when the Boston Lying-in Hospital was founded, largely as a result of Walter Channing's influence. It was located at the southern end of Washington Street, just beyond where Tufts New England Medical Hospital is today. The Lying-in was a charity hospital meant for poor or homeless women who had no other adequate place to give birth, a situation with which Channing was sadly familiar, having delivered babies on the floor in some of the squalid tenements in Boston's slum areas. In the early days of the Boston Lying-in, the patient load was small, averaging less than 30 cases per year, and it didn't look like you would expect a hospital. It was a home. They had bought a home, had a garden around it. It was way down, almost out of the city. They didn't want these women contaminating the closer in women. I think that was part of the problem. But in the early days of the hospital, about 30 patients a year, not more. And this was an indication of the unwillingness, even of very poor women, to give birth in a hospital. Women were genuinely afraid of hospitals. They really didn't know what to expect. There was a certain shame attached to needing charity care, and there was an increased risk of infection. On the other hand, once there and pleased with the relative comforts, decent food, cleanliness, and warmth, Many patients at the Boston Lying-in Hospital remained long after the baby was born. And you couldn't blame them. Traditions in the hospital, though hardly luxurious, were much better than they knew elsewhere. Middle and upper class women delivering at home also spent days, even several weeks, in bed after the delivery of their babies. There were also women who came to the hospital weeks before delivery, perhaps because they had no way to be sure when conception had occurred or when they first felt life. So they had no way to estimate when the baby was due. Channing published extensively on obstetrical topics, sharing the benefit of his knowledge with physicians throughout New England. None of his contributions to obstetrical practice or to women's reproductive health and the improvement of their lives was ultimately as important as his advocacy of the use of anesthesia in childbirth. It's difficult in retrospect, to understand why there should have been opposition to anesthesia in Channing's day, but there was. Many prominent physicians, as well as clergymen and lay people, were quite adamant on the subject. And so Channing's efforts on behalf of anesthesia were vastly important. Now, the first successful demonstration of the effectiveness of ether, the first anesthesia that was ever used, occurred in 1846 at the Mass General Hospital when John Collins Warren, a noted surgeon, removed a tumor from the neck of a young man. And that young man had been anesthetized by William Morton. Morton was a dentist who had experimented with ether in his dental practice. It wasn't a bit difficult for anyone to accept the use of anesthesia in surgery or in dentistry, but there were many, many objections to its use in childbirth. Some of them quite valid. No one really understood how it worked. What was the proper dosage? For how long it could be safely administered? Whether it would slow contractions, whether it would have a negative effect on the baby, and so on. Also, there was a widely accepted religious objection. The pain of labor was God's punishment for all women because of Eve's sin in the Garden of Eden. And as we are told in the book of Genesis, chapter 3, God said to Eve, I will greatly multiply thy pain and thy travail. In pain thou shalt bring forth children. Many 19th century people took this quite literally and accepted it as an unalterable edict. And there was another popular belief held by many that the pain of labor was a positive good. It strengthened the bond between mother and child. Channing was not the first American doctor to use ether in a case of childbirth. That's a wonderful story that centers on Fanny Longfellow, the wife of the poet Henry Wadsworth Longfellow. Fanny decided on her own that she wanted anesthesia for the delivery of her third child. It had never been used in this country, but she was aware that obstetrical anesthesia had been used successfully in Europe. So when labor began, Nathan Cooley Keep, a dentist who had trained in medicine, was summoned to the Longfellow house right on Brattle Street in Cambridge. Keep administered the ether, a midwife delivered the baby, and everything went well. So well, in fact, that the very next day, Henry crossed the river from Cambridge to Boston, where Dr. Keep removed the stump of a tooth from his mouth. Parenthetically, Henry was much criticized by friends and family for allowing Fanny to experiment with such a potentially or seemingly potentially dangerous drug. She, on the other hand, showed real grit, I think, by writing to her sister that she was proud to be the pioneer to less suffering for poor, weak womankind. That tells you something about women's views of themselves. Channing was the first to use it in operative midwifery, a case in which forceps
forceps had to be applied, usually painful for the mother, dangerous for the baby, and stressful for the physician. He was so pleased by the outcome, as was the mother, that he continued to use it in subsequent deliveries and then in normal deliveries. He concluded that it was safe and effective, and he published a series of articles in the New England Journal attesting to his confidence in ether. In one, he described a patient who initially refused the sponge on which the ether had been poured. But once she was under its influence, it was difficult to persuade her to give it up. After the delivery, she sang, talked, and swung her arms in the air. When she heard the baby cry, she put her hands to her abdomen, as if to learn what had happened, and she was surprised to find that the baby had been born. Another woman had been crying out in great pain, I am dying, end this horror for me. But after the ether took effect, she was a completely different woman, and she kept murmuring, how beautiful, how beautiful. The following year, after he had first begun his experiments and his cases using anesthesia, he attempted to reassure the larger audience by publishing a book which he titled A Treatise on Etherization in Childbirth. His book was based on a detailed survey he had conducted among local physicians, because many other quickly adopted this. And he had surveyed local physicians about their experiences with anesthesia in childbirth. In 516 cases of natural births, that means no instruments, no complications, there were no deaths. In another group of 52 births involving instruments or other complications, there were 4 fatalities, but all were ascribed to convulsions which would have occurred anyhow, and not to the anesthesia. And Channing found evidence that in the non-fatal cases, the instruments were used much more easily, with less pain to the patient, and that turning the fetus, necessary if it were not in the proper position, was considerably facilitated by anesthesia. The treatise included careful directions for application of the ether. There was no anesthesiologist present, so Channing had worked with an instrument maker here in Boston to develop a cone which fit over the mouth and really the face of the woman and enabled the ether to be applied much more directly. When it was put just on a sponge and there was no baffling protecting it, the ether would permeate the entire room and was very unpleasant for everyone. So this cone was an important addition to the application of anesthesia in childbirth. Channing also included a refutation of that negative religious argument that I spoke about before. In a letter written at his request, one of the liberal professors at Harvard Divinity School had declared that human ingenuity used for the relief of pain is the use of God-given means by God-given powers. This was also Channing's philosophy. He was immensely pleased to have shown the advantages of obstetrical anesthesia. May we not look with confidence, he wrote, to the time when labor is accomplished with an ease, a freedom from suffering quite as great as has hitherto been the pain which accompanied it, and which has been regarded as its necessary condition. Channing was very active, apart from medicine, in some of the social reform movements in antebellum Boston, and I bring that up because this house is so much associated with some of those things. He was involved with the temperance movement. He was involved with abolition. He was especially interested in the temperance movement and in efforts to soften the worst effects of increased industrialization and urbanization. He wanted better housing for the growing underclass that was living in slum conditions, and he wrote about it. He wanted to improve the dreadful water supply, and he wrote about it. And he was concerned by the plight of men, many of them immigrants, who had recently been released from prison and had no home places to live and found it very difficult to get jobs and support themselves. Now, many physicians did not take part in these social causes, but Channing saw his role as an extension of his role in medicine. It was all too obvious to him that there was a relationship between disease and poverty, and I sometimes wonder why we have to rediscover that relationship every 10 years. One of the ironies of Channing's life as a physician was that he was helpless when confronted by sickness and death in his own family. It should be said here that this was true of many doctors who, despite their medical knowledge, were not able to save the sick in their own homes. Channing's first wife and the mother of his 4 children died aged 27 from tuberculosis. His youngest daughter also died of tuberculosis when she was 25. Perhaps the greatest tragedy in Channing's life was the death of his second wife, Elizabeth. She had rescued Walter Channing from the loneliness and bouts of depression that followed the death of his first wife, and she had created a warm and happy home for him and his children up there on the corner of Tremont Street. But 3 years after their marriage, she died in childbirth, following the instrumented delivery of a stillborn child. And Channing had been the doctor. He was the attending physician. And here he delivered his stillborn son and then watched his wife die. It was hideous. He literally went to pieces. For a day or so, he was totally incoherent, and if it hadn't been for the ministry of his brother, who stayed by him and tried to talk to him and read selections from the Bible and so forth, he may well have absolutely tipped over. Fortunately, he was a deeply religious man. It took immense faith to accept what had happened, but eventually he recovered and he resumed his medical practice. And also, it's obvious, it was not uncommon for physicians to deliver their own babies. Channing had delivered his 4 children from the first marriage, but it's easy to understand why that's no longer acceptable. At the age of 78, Channing was still responding to nighttime calls, though he had long since retired from teaching or hospital duties. In one of his final cases, the summons came at 4 a.m., and he went. Patient was well past her due date and had begun to bleed severely. Fortunately recognizing the limitations of his years, he wisely requested assistance from a younger colleague. In his old age, Channing often pondered the lessons of his life in medicine. He had not lost his fascination with the profession he had chosen. Medicine satisfied his great need to be useful. He had helped bring new lives into the world. He had given relief to the sick and the dying, and he had endeavored to prevent disease. Medicine satisfied his hopes for the future, as he had conscientiously instructed generations of young physicians. And it was intellectually challenging. Medicine, he wrote, asks perplexing questions. What is life? What is growth? What is this perpetual motion? And how is it sustained? Channing never found the answer to these questions, but the quest had fully engaged him throughout his long and productive life. Thank you. I'm told we have time for just a question or two. Yes. Wait a minute. She's coming with a mic, so everyone can hear you.
How old was the second wife when she died?
She was in her mid-30s. Yeah, that was one of the fears. She was considered too old for a first baby.
Could you say more about the hygienic methods and asepsia?
None. No, there wasn't antisepsia. There was none. This is before bacteriology. This is before Pasteur. It's before Lister. Nobody understood what caused infection. I assume he washed his hands, but I don't know. And he didn't write about washing his hands.
He sounds like a really admirable person, and I wonder if you could say how what he did with his patients maybe was an improvement on what the midwives did, the traditional way.
I could. It's a huge, long story. But essentially, because the midwives were not educated, they had required no education. Midwives learned. We're not talking about today's midwives. We're not talking about 21st century or 20th century midwives who are licensed, who are trained, etc., who are literate. Many of the midwives did not read. Those who did, and there were many who did, still had no education beyond grammar school or whatever, and they learned to be midwives by watching other midwives do what they did or learn from their mothers, that kind of thing. So what they did in most cases was perfectly fine, because in most cases there are no problems. A baby is born. Baby is supposed to be born with no complications. What he could do was handle cases in which there are complications, in which there's hemorrhaging, in which the baby is impacted, in which the baby is not properly positioned in the pelvis and so forth. And it's because women were fearful of the negatives, fearful that some of the terrible things might happen to them, and knew that a physician had a better chance of saving them, had a better chance of producing a healthy, living child, that they switched from asking a midwife to come to asking a doctor to come. In most cases, it wouldn't make any difference. But, of course, as obstetrics became more and more of a specialty to what it is today, where it's such high-tech stuff, that's a whole other story. But that's why midwives today operate in hospitals, and when they don't need the high-tech stuff, they're perfectly fine. Yeah.
Was it the custom in those days that, as it more or less has become to a certain extent now, that if something happened that the baby was lost or the mother was lost, that they'd blame the doctor for it? Or was he just considered?
Well, there was no medical malpractice. There were no suits, if that's what you mean. He was never sued.
I meant like personal blame. Don't go to Dr. So-and-so.
Oh, it's possible. I'm not aware of it. I'm not aware. They all had their reputations. You know, this is a time when people are dying much more frequently than they are now. And if a doctor lost a patient because of a cancer or because of a strep throat or because of infection from a wound, people assumed there was nothing that could have been done, because in most cases there wasn't. A doctor had to be do egregiously bad things for him to be blamed for it. There's this notion, you know, it's the will of God. The doctor does his best.
At this time, were the practices in Italy, and I was thinking of the University of Bologna, which I think had a very good medical school, and in Moorish or Arabic countries, was that? Do you know if that was superior in terms of their general medical practice? Or?
It was considered, sure, because that's why Channing went to Britain. He went to London and Edinburgh to study, and the most ambitious doctors in our country would go to England or go to Paris. They were considered much more advanced. Yeah. Bologna, not many Americans went to Italy, but they did go to Paris. And first Britain. You know, we're practically not much removed from being a British colony, so the national tie would be with Britain, and that's where they went. Subsequently, Paris became the leading medical center in Europe, surpassed Britain. And Holland was always in there somewhere. But yes, you're right, and much of what doctors learned in Paris, what they learned in Britain, they brought home here. And then if they became professors, they educated the younger men, only men, and no women. They educated the younger men in these more advanced practices and better knowledge. Yeah. I think this is it. Thank you. If anybody is interested in buying a book, if I've interested you in the topic, I'll be happy to sign it.